Oops.
Ooh. You guys got to see the great reveal. Okay, now we're going to talk about special tests. There aren't a whole lot. There's 7 special tests that we have for the feet or the foot and ankle. And they're all relatively pretty simple. So we're just going to start going through them. The first one on there is the anterior drawer test. I can talk. It looks a lot like and is performed in a very similar way to the anterior drawer for the knee, in that all we're really doing is giving a mild thrust anteriorly to try and stress those structures that would normally hold that position. Okay? For anterior drawer, we are testing the integrity of the ATFL specifically. So if our patient, like you saw in the last video, has had a lateral ankle sprain where they've gone into extreme inversion, and we anticipate that there's a rupture of that ATFL ligament, then we're going to perform the anterior drawer. Quite simple. We're going to grab their calcaneus on the posterior side. I'm going to support the tib and fib and get my patient to relax, and then I'm going to give a nice pull anteriorly. I'll do with this one so you can see as well. I'm just going to pull anteriorly, and again, we're just looking for any excessive motion or movement, because that ATFL is not holding like it should, and so it's allowing more motion to occur than we would anticipate. Again, I guess I failed to mention this, when they're relaxed, ideally you just want them kind of in a more neutral or normal relaxed position, which tends to be not neutral, but more like 10 to 15 degrees. Plantar flexion, and then I'm just going to do that anterior pull. Nothing happening. Nice strong ATFL. Next, we've got our talar tilt, which again is testing for the integrity of ligaments. This time it's not just the ATFL, but also the CFL and the PTFL. So again, like you saw in the other videos, the ATFL sits here, CFL sits here, PTFL sits back here. We're going to try and kind of tease all of them and grade the integrity of them, just to make sure everything looks good. So we're going to again have them kind of go into a relaxed position, and I'm going to same hand hold as I did for that anterior drawer, but instead of pulling forward, I'm going to pull him into inversion, true inversion of the rear foot, and see if we get excessive motion. If we do, then we know that we've got some integrity issues with those ligaments. We may have what they call gapping, we'd have some translation, or the patient could say that does not feel good, and those would all be considered a positive test. The Thompson test, again looking at the integrity of a structure. This time we're looking at the integrity of the Achilles tendon. So I'm going to have my patient flip over on his stomach, and I'll bring him up to 90 degrees of knee flexion, and then while I've got him there, I'm going to squeeze his gastroc, and I want him to just be loosey-goosey here. And as I squeeze the gastroc, you'll notice that he's going into plantar flexion. That's just because I'm increasing the tension on the gastroc muscle, like it was contracting, and that tension pulls on the calcaneus or not calcaneus. Well, it does pull on the calcaneus via the, I just forgot what it's called.
Achilles tendon.
Achilles tendon, thank you, and causes that dorsiflexion. This does not tell us, so if we don't get that movement, then we would consider it a positive Thompson test. So if there's a lack of movement, it'd be considered a Thompson test. This does not tell us if there's a complete rupture. This just tells us that there aren't enough of those fibers that are attached to cause that motion to occur. To determine if it is a truly a complete rupture, they would have to have imaging. But this will at least tell us, yep, there's bad enough in there that you probably should go get imaging done, and you're probably going to need surgery, kind of thing. Okay. The next one, Windlass Test. So this one is for plantar fasciitis. Yeah, I'll just have you stand up here. We're gonna have him stand up here, and his toes will be right off of the edge. If you're worried that maybe your patient isn't able to stand on the plinth like this, doesn't have balance, then you can grab a stool and have them stand on the stool, again with their toes just kind of hanging off. The kind of crazy thing about the Windlass test is, so we're testing for plantar fasciitis, but we can get a variety of results from it, okay? A positive Windlass test could be that they have pain when we take them through this motion. It could be also that the big toe doesn't move, so we're not going into very much extension. Conversely, if we go into way too much extension, like way past 90 degrees, then that too could be considered a positive test. That doesn't happen as often. You're looking more for pain or a lack of range of motion to give you that true positive. So I'm here, I'm going to grab his big toe, and I'm going to pull it up, and again I'm looking for pain or anything that's significantly less than what I would consider to be normal. He's coming up pretty good, so I wouldn't be too worried about it. The other one again is if we're able to go up to that 90 degrees or even farther, then there is something wrong with that plantar fascia. Next, we've got impingement sign. So for this one, we're testing for just what it's talking about, or the name implies. I'm going to make sure that our camera's looking in the right spot. There we go. So for impingement sign, we are looking for any type of impingement, or that's what we're testing for, to determine if there are some sort of structures that are here on the anterior side, kind of anterior lateral side of the foot, that are becoming impinged in between the talus and the tib fib, that joint capsule there. So it could be cartilage, could be some sort of ossifications, could be all sorts of random things that are getting sucked in there or causing that. Again, we're looking for, this is a provocation test, which simply means that we're looking for or looking to reproduce any symptoms that the patient might have. So I'm going to take the patient into maximal dorsiflexion for the actual test, but before that, I'm going to take my thumb and I'm going to find that joint and apply some pressure. And then I'm going to take him into that maximal dorsiflexion. Again, we're looking for any reproduction of symptoms, which could simply be pain, could be they're feeling tightness in there, it feels like a pinching feeling. Depending on the structures that are getting impinged, if we hold it long enough, they may start to feel tingling or numbness or anything along those lines. Tunnel's sign. You guys will learn another type of Tunnel sign for carpal tunnel syndrome. So this is very much the same thing. We're testing the anterior branch. I got it written down here so I don't forget. Anterior branch of the deep peroneal nerve, or the posterior tibial nerve, which run right down through here underneath that medial malleolus. Okay, and so we're going to hold on here and find that kind of soft spot, and we're just going to tap it. And again, it's a provocation test, so we're looking for any type of nerve type symptoms where maybe they have like a numb zing that kind of goes through, or like their toes or fingers are just waking up because they've been sitting on it wrong or something along those lines. So that's for the Tunnel sign. Again, tarsal tunnel syndrome. The last one is, you've heard me say it, and I would assume James has probably said the same thing, that this is like a horrible test, the Homan's test. You can do it a couple different ways. We are testing for DVT in the calf, which when we do the test, you'll be able to hopefully realize or figure out why it's a terrible test. Again, I think we may need to adjust up a little bit here. There we go. Because the way you do the test, it increases the possibility of actually dislodging that DVT. So let's say that we suspect that James has a possible DVT in his right leg here, and I want to do a test to see. So I come and I go like this, and I push into maximal dorsiflexion, and because it's tightening up those calf muscles as I do so, then obviously if there is a DVT, it would cause him pain, he would not like it, and there's a possibility we could dislodge that. The other way you can do it is by grabbing the calf muscle and squeezing. It seems like a good idea, right? Hey, there's maybe a DVT in there. Let's see if we can dislodge it and send it to your brain. Not the greatest. So that one's not on your skills check. It is on the paper. We have it there more than anything just so you know what it looks like and kind of see that it's really just a dumb test. There's like questionnaires and things out there that are far better at determining if there is a positive for a DVT. One of the easiest ways is to look at it. If it's swollen, if it's red, if it's very sensitive to just light touch. Sometimes patients will say that even just their pants rubbing up against their leg causes them pain, then those are all signs that there's probably a DVT, and so you just need to go get some imaging done and get them treated for it. But those are the special tests that we have for the ankle and the foot. Again, pretty simple. So now that you've watched hopefully both of these videos, you get to go and write about it. Yay! And we'll see y'all on Wednesday.